This module looks at the practical aspects of somatosensory evoked potentials, and we will discuss patient parameters, stimulation, montage, waveforms, and recording parameters. Somatosensory evoked potentials are used to assess the functional integrity of the sensory pathways that traverse the spinal, subcortical, and cortical areas. The SEP is generated in response to sensory nerve stimulations, where the stimulators are placed on the limbs, and the signal travels up the limb, through the nerve root, and enters the spine into the dorsal column. The signal then travels up through the brainstem, the thalamus, and to the sensory areas of the brain. Because the signal travels such a long distance from the site of stimulation up to the brain, SEPs actually test the longest neural pathways in the body and are therefore very sensitive in demyelinating conditions. In fact, SEPs may even detect subclinical lesions. As we have just discussed, SEPs are indicated in demyelinating conditions and dysmyelinating conditions as they are able to test a long neural pathway and are sensitive to lesions along the pathway, even very subtle lesions. SEPs can also be used to differentiate peripheral from central disease by looking at the patterns of abnormalities between the absolute latencies and the interpeak latencies. We will discuss this further in the module on clinical correlations. The SEP will not be normal. It cannot be normal if the patient has a peripheral disease such as a peripheral neuropathy, or if there is anything that impedes the conduction of the signal from the site of stimulation into the spine. This will affect the entire SEP. The SEP response over the spine is very small in amplitude and is easily obscured by muscle artifact. The patient is typically tested in a lying down supine position, and they need to remain quiet and still. The neck, the back, and the limbs need to be relaxed. If the patient has a significant amount of adipose tissue, it may be hard to obtain a good stimulation because there's poor access to the nerve, and it may be very difficult to obtain a good spinal recording either at the lumbar spine or the cervical spine. Of the three evoked potential modalities most commonly recorded in a clinical setting, the SEP is the one most affected by external factors. These factors include limb length, which changes the latency of the peripheral responses, patient age, which affects myelination maturity and changes the latencies, particularly of the peripheral responses, but also of the interpeak latencies. The temperature of the patient, as the conduction velocity slows down if the patient is cold or has undergone hypothermic therapy. As well, limb integrity affects the SEP if there is no access to the required stimulation site, and sleep and sedation will affect the SEP, which we will discuss in the next slide. Patients can be tested while asleep, and patients who cannot lie still may require sedation. Recording in sleep or recording with sedation allows for good recordings of the spinal components. However, after recording the spinal components in sleep or sedation, patients need to be slightly awakened to allow better recording of the cortical components, as these are usually smaller and poorer if the patient is soundly asleep or sedated. It should be noted that in babies, we are often answering a different clinical question. Typically, the clinical question is of prognosis or cortical function. Therefore, we are typically only looking at the cortical response. It is typically not feasible to place peripheral or spinal electrodes on a baby or a young child due to their size and possibly due to their cooperation. Therefore, it is essential that the technologist indicate whether a motor threshold was attained, as this is the only indication of stimulation integrity. Also, it's very important to know whether the baby was sedated, sleeping, or slightly awakened, as sedation and sleep effects will reduce the amplitude and delay the latency of the cortical SEP. When acquiring the SEP, if the technologist notes that the baby is in deep sleep or sedated, and the cortical SEP looks to be poor or delayed, it is sufficient to rouse the baby slightly and record any improvement in the cortical SEP so that for interpretation it can be noted that there was a sleep or sedation effect. The two most commonly recorded clinical SEPs are the upper limb SEP, usually acquired by stimulation at the median nerve, and the lower limb SEP, usually acquired by stimulation of the posterior tibial nerve. This is a picture of the SEP stimulator and electrode. The stimulator has a dial that adjusts the intensity of the stimulation. It's always a good idea to start at 0 and still slowly dial up until the motor threshold is obtained. This motor threshold is seen as a thumb twitch with a median nerve stimulation and a plantar flexion or a downward twitching of the big toe with a posterior tibial nerve stimulation. The electrode is plugged in with the red pin to the positive and the black pin to the negative jacks. The electrode is bipolar with the anode closest to the wire, and the cathode is the electrode further away from the wire. The stimulus bars are placed on the median nerve on the dorsal surface at the wrist crease between the tendons of the palmaris longus and the flexor carpi radialis muscles. These two tendons can be easily seen if the patient is asked to flex the wrists against resistance. The two tendons will pop up and the stimulus bar is placed between them. The anode is placed 2 centimeters distal to the cathode, meaning that the wire will run down the hand. The ground lead is placed between the first recording electrode and the stimulator. The ground electrode, which often consists of a plate or just an electrode, is usually placed on the palmar surface of the forearm. Sometimes it's not possible to access the median nerve. The patient may have an IV at the wrist or arm or a cast or something that prevents good placement of the stimulus bar. If this is the case, then the stimulator can be placed at the median edge of the cubital fossa, that is, on the inside of the elbow, where the median nerve wraps around to continue travel up the arm. The stimulator is still placed with the anode distal and the wire running down the arm, and ideally with this placement, a motor threshold is obtained. When the stimulation is at the elbow, the ground electrode is moved up to the upper arm so that the ground electrode is still between the stimulator and the first recording electrode. The stimulus bars for the posterior tibial nerve stimulation is usually placed midway between the medial, the inside border of the Achilles tendon, and the posterior border of the medial malleolus, which means it's placed on the inside of the ankle about halfway between the back edge of the ankle bone and the back edge of the foot. Again, the anode is distal, so the wire runs away from the body. The ground electrode is placed between the stimulator and first recording electrode, which is usually at the knee, so the ground is placed somewhere on the lower leg. If it is not possible to access the ankle and stimulate the posterior tibial nerve at the ankle, an alternative site is to stimulate the common peroneal nerve at the knee. The stimulator bar for a common peroneal nerve stimulation is placed at the knee with the cathode below the leg crease towards the lateral or outside part of the popliteal fossa, but medial to or towards the inside of the tendon of the biceps femoris muscle. The biceps femoris muscle tendon can be easily seen if the patient is asked to bend the knee against resistance. The anode is 3 centimeters away from the cathode down the leg with the wire running down the leg. The ground electrode or ground plate is positioned mid-thigh between the stimulator and the first recording electrode, which will now be the electrodes on lumbar spine. The motor threshold for a common peroneal stimulation is an eversion of the foot or an outward twitching of the foot. For the upper limb recording montage, I will show you first the montages contained in the guidelines, and then we'll talk about what we do at Sick Kids. The upper limb SEP recording montage consists of 4 channels. The first channel is a cortical recording where the active electrode is placed over contralateral somatosensory cortex and reference to CZ. This means that if the right median nerve is being stimulated, then the recording electrode is at C3'. C3' or C4' when it's a left median nerve stimulation is located 2 centimeters behind C3 or C4 using the 1020 electrode placement system. This recording is a near-field recording with both the active and reference electrodes on the head. The channel 2 recording used in the guidelines is also a cortical recording with the active electrode over contralateral cortex, such as C3' or C4', reference to a non-cephalic electrode, such as Erb's point, instead of a cephalic electrode such as FZ, which we saw in channel 1. So the channel 2 recording, because it's referenced to a non-cephalic electrode, is a far-field recording of subcortical components and a near-field recording of the cortical components. So it's a mixed recording. The channel 3 recording is acquired over cervical spine. Any of these 3 electrodes at C2, C5, or C7 may be chosen. When the patient is asked to bend their head forward, the bony prominence at the base of the neck is C7. Counting up 2 vertebrae, one can find C5, and then C2 can be found as the deepest indentation a few centimeters below the inion. Any of these 3 electrodes can be chosen as the active electrode and referenced to CZ. The 4th channel is a peripheral recording from ipsilateral Erb's point to contralateral Erb's point. The Erb's point electrode is placed by asking the patient to turn their head to one side. When they do this, an angle forms above the collarbone where the posterior border of the sternocleidomastoid muscle meets the clavicle. If one measures 2 centimeters above the clavicle into this angle, into this space, one can place the Erb's electrode here. At SickKids, we only record 3 of the 4 channels, and we do not record the cortical far field montage. And so we only have a cortical, a cervical, and a peripheral recording. And we are still able to localize within the upper limb somatosensory system using these 3 montages. In a lower limb SEP recording, there are typically 5 tracings. Channel 1 is usually the cortical response with the active electrode at CZ', which is 2 centimeters behind CZ along the midline. This is referenced to a far frontal midline electrode, such as FPZ'. Typically, there are 2 or 3 lumbar channels, which usually consist of pairs of electrodes along the spine, with the lower electrode being the recording electrode and the higher electrode, that is the one closer to the head, being the reference electrode. These active electrodes could be placed at L3 spine, T12, or T6 spine. The references could be placed 3 to 4 centimeters above the recording electrode. L3 spine can be found by pretending to draw a line between both iliac cresses and finding the vertebrae at this line. L5 spine is 2 vertebrae inferior to L3, and L1 spine is 2 vertebrae superior to L3. The peripheral response is recorded by placing an electrode in the popliteal fossa 4 to 6 centimeters above the popliteal crease between the 2 prominent tendons. The reference electrode can be placed on the medial side of the knee. At SickKids, our recording montage is a little different to make it easier to apply the electrodes and to see the waveforms. The cortical response at channel 1 is recorded at the vertex, or CZ, referenced to a frontal electrode FZ. The lumbar responses are recorded from the L1 vertebrae referenced to the iliac crest, L5 referenced to iliac crest, and L5 referenced L1. This allows us to identify the lumbar waveforms by observing a phase reversal between the iliac crest L1 montage and the L5 L1 montage. Also, we should see movement of the lumbar waveform with it being slightly earlier in the iliac crest L5 montage compared to the iliac crest L1 montage. The iliac crest can be found by placing a hand at the waist and pressing down. The bony prominence that can be felt is the iliac crest. For the peripheral recording, we reference to the other leg to reduce the number of electrodes that need to be applied. This slide shows the obligate waveforms for a median nerve SEP. The top tracing, channel 1, shows the cortical response, with the obligate waveform being the N20. This is a negative going trough at about 20 milliseconds after stimulus onset. We typically see an N20 P22 complex. In channel 2, which is the second cortical recording with a non-cephalic reference, what is typically seen is a P14, a subcortical response, and the N20, which is a cortical response. In channel 3 for the cervical recording, the obligate waveform is the N13, although what is often seen is an N12, N13, little w complex. And in channel 4, the peripheral response is seen as a negative going, sharply peaked response at about 9 milliseconds post-stimulus onset, and this is called the N9. With the 3-channel montage that we use at SickKids, we typically will see an N20 P22 in channel 1, the cortical recording. We'll see a little W, a set of negative going peaks called the N12, N13, which are the cervical responses in channel 2. And then in channel 3, which is our peripheral response, we will typically see a negative going N9. The obligate waveforms for the posterior tibial nerve SEP consists of several cortical responses in channel 1, typically a P37, N45. The P37 is named this because it's typically around 37 milliseconds after stimulus onset, and it's a positive response. The middle 3 channels, channels 2, 3, and 4, will show some form of the lumbar response, and the obligate component is the P21. And then finally, in the 5th montage, this is the peripheral tracing, and what is seen is a popliteal response at about 9-10 milliseconds after stimulus onset. This slide is an example of the posterior tibial nerve recordings that we typically obtain at SickKids. The top channel is a cortical recording, and we usually see a big M-type response where there's not a very negative going N30, but kind of the bottom of the peak, and then a positive going P35, and then a negative N45, and then a positive P55. The obligate waveforms are actually the N30 and P35, so there's a lot of individual variation around the N45, P55, and it's not obligated that they are seen in every single person. There's a lot of individual variability in the presence of the N45, P55. The middle 3 tracings are the lumbar responses, and the obligate waveforms are the N18, P21. And what we're looking for, it's very subtle, is a phase reversal between 2 of the peaks. And that phase reversal is typically the P21. And so by looking at the latency, the approximate latency where we expect to see the peaks, and then looking for this phase reversal, that's how we identify the P21. And then the negative going portion before that would be the N18. In the bottom tracing, this is the peripheral response. We typically see a fairly large, clear, negative going peak, and that's the popliteal response. The previous slide showed a very nice cortical and popliteal response. However, the lumbar responses were not so clear. In this slide, the lumbars are very well formed, and the cortical response shows a fairly typical individual variation. And so I have already mentioned that a typical variation for the cortical response is to only see the first peak, the N30 P35, which is what we see in this case, and the absence of an N45 P55 is an individual variation and not of clinical significance. I'd like to use this slide to explain the lumbar responses because they are very clear. You'll note in this slide that we have 3 lumbar montages, an L1 to iliac crest, an L5 to iliac crest, and an L1 to L5. I'm going to start with the 3rd montage, the 3rd lumbar response, the L1 to L5. This is the typical montage used in adults, and so in this montage we expect to see the negative going N18 and P21, which is what we see in this example, and it's marked with the blue pen. The other two montages, both the L1 to iliac crest and the L5 to iliac crest, should phase reverse with the L1 to L5 tracing. We see this in the middle tracing with the L5 to iliac crest montage, but the tracing is not so clear in the first one, the L1 to iliac crest recording. This is a list of the recording parameters for the somatosensory evoked potentials according to the guidelines. So for both upper and lower limb somatosensory evoked potentials, the stimulation rate can be between 4 to 7 hertz. The stimulus duration is very short. It's an electrical stimulation that's between 200 to 300 microseconds. The low frequency filter is set between 5 to 30 hertz and the high frequency filter between 2500 to 4000 hertz. The minimum sweep time, the recording time for one trial for a median nerve SEP is 40 milliseconds, although if there is a known delay or if the patient is really tall, one could increase this up to 60 milliseconds. For a posterior tibial nerve recording, the minimum sweep time is 60 milliseconds, and it can also be increased up to 100 milliseconds if there's a known delay. The number of trials that need to be recorded for an upper limb SEP is a minimum of 500 up to 2,000, and for a lower limb SEP, a minimum of 1,000 up to 4,000. And for both upper and lower limb SEPs, the motor threshold is typically reached at below 15 microamps. In children, the recording parameters are adapted to reflect the immaturity of the somatosensory system. And so the first thing to note is that the stimulus rate is much, much slower. In preterm neonates, it's 1 every 2 seconds. And then in a newborn or up to a 3-month-old, it might be 1 per second. And it's not until 3 months that we would start to stimulate children at close to the adult rate of 4 to 5 hertz or 4 to 5 stimulations per second. The band passes are also different in the children versus the adults. And so in the children over 3 months, it's getting close to what is used in the adults. But in the younger children, the band pass is lower. So the low frequency filter and the high frequency filters both are lower. As well, the gain is higher in the young children. Another big difference between children and adults is the sweep time or the length of the recording time. And you'll note that in the preterm neonates, we record for 500 milliseconds, which is really quite long. And then in the newborn, we can record up to 200 milliseconds per trial, whereas by 3 months, we're at 50 milliseconds, which is approaching the typical recording times for adults. What's interesting is the number of trials is counterintuitive. So because the scalp is thinner in children and the recording electrode is right over the cortex, fewer trials are needed, fewer stimulations are needed to record a good response. So in preterm neonates, 25 to 40 trials should give us a good response if one is present. In newborns to 3 months old, 50 to 60 trials is often sufficient, whereas in children over 3 months old, we need 250 trials, which is approaching the numbers that we would use for an adult. The other thing that's interesting is that the motor threshold is much higher in the preterms and newborns because the nerve system is not as well myelinated. And so for this reason, it doesn't conduct as well, and so a higher stimulation threshold is required to get a motor threshold in the babies. At 3 months of age, we're using stimulation thresholds that approach what is used in adults. Now for posterior tibial nerve stimulations, these same parameters apply, and so using slower stimulus rates, lower band passes, longer sweep times, and lower numbers of trials. For the PTN, we could use these parameters in young children. However, it should be noted that it's very difficult to acquire posterior tibial nerve SEPs in babies, and so it's typically not done.